Hello and good evening, everyone. I'm Dr. Gayasi. We've all gathered here today to talk about the role of physiotherapy in motor neuron disease, or else it is also known as amyotrophic lateral sclerosis. So, without further ado, I would first like to talk about what motor neuron disease is. So, motor neuron disease is a rare but fatal syndrome characterized by signs and symptoms of degeneration of upper motor neurons and lower motor neurons in the cerebral cortex, brainstem, spinal cord, leading to progressive weakness of bulbar, limb, thoracic, abdominal, and respiratory muscles. Other brain functions, including oculomotor and sphincter functions, not necessarily but relatively are spared. So the incidence of ALS or MND, as we stated earlier, it has an incidence of 0.6 to 2.6 per 1 lakh of the population, and a mean onset of 47 to 52 years in familial cases, and 58 to 63 years in sporadic cases, but can occur at any age. The main risk factors being male sex, increasing age, and hereditary predisposition. They tend to be the main risk factors for ALS and MND. Uh, Death occurs on an average from 2 to 4 years from the first symptom of the respiratory dysfunction, but a small group may survive for a decade or more. Well, of course, it depends on the kind of measures that we take for prevention, for caution, for maintenance. Depending on that, these data and the dates have been collected. So the skeletal symptoms include progressive muscle weakness and atrophy, muscle fasciculations, abnormal contraction of the muscles, which is what fasciculations are, cramps and spasticity, while bulbar symptoms include dysarthria, dysphagia, and synuria. Patients may also present with fatigue, venous compromise, pseudobulbar emotional liability, depression, anxiety, pain, respiratory compromise. Impairments present in people with MND limit the ability to perform daily activities and to participate in everyday situations, impacting their quality of life. So now let's talk about the role of physiotherapy. What role does it play in the management of motor neuron disease or amyotrophic lateral sclerosis? So, physiotherapists have a broad range of skills relevant to the support of the patient with MND. Over the course of the disease, they have a significant role in the provision of aids and appliances, prescription of exercise programs, pain management, and respiratory symptom management. Increasingly, evidence suggests that exercise is beneficial in maintaining muscle strength, aerobic and pulmonary function, and quality of life in patients with MND. So the physiotherapy management evolves through the early, middle, and late stages of MND. Specific physiotherapy management through each stage is dependent on the patient's presentation at that particular stage. So as we spoke, there are three major stages to consider in MND: the early stage, the middle stage, and the late stage. So in the early stage, the patient can mobilize and manage activities of daily living independently. There may be weakness of specific muscles that limit performance of tasks or endurance. Common deficits noted at this stage may be foot drop or weakness of intrinsic muscles. Um, Similarly, in the middle stage, the patients may be abundant to some degree, but it is likely to have severe weakness in certain muscle groups. Spasticity may become an issue, and significant limitations to activity and participation will be emerging. There may be some evidence of respiratory insufficiency, and the patient should be taught techniques to support lung expansion and secretion clearance. The last stage, it is characterized by the progressive weakness and deterioration in mobility, dexterity, and endurance. At this point, the patient is generally wheelchair dependent and/or may present with respiratory compromise. A hoist is likely to be required for transfers, and pain can be a problem. Patients with progressive bulbar palsy may maintain mobility but present with severe respiratory compromise and should be managed accordingly. So now these three stages, considering the main aspects, So in the early stage, the majority aspect to be focused upon is to maintain the mobility and function and prevent falls, the respiratory symptom management, fatigue and anxiety management. Whereas in the middle and the late stage, there will be pain management also to be considered. So let's talk about these factors, the strategy, and the recommendations for a physiotherapist in each stage for each strata of the table. This is just to summarize. There's this table, so we could just go through it once. Uh, this is the early stage, the middle stage, and the late stage. So now talking about the treatment management, often the goal of physiotherapy in the care of people with MND is not to improve impairment in strength or mobility due to progressive nature of the condition. Basically, this one statement is very important. Uh, our goal is not really massive or huge changes that we get to see in MND, but maintaining the condition, maintaining the independence, maintaining the functional mobility is what the major task is. So instead, the therapy is aimed at assisting the patient to maximize function through provision of aids and appliances, mobility strategies, and respiratory management. However, it is important that problems with pain are managed where possible with a restorative approach. As the disability progresses, a patient's care needs may require the application of proper lifting and handling techniques, implemented in ways that ensure the safety of the patient and the carer. Early provision of hoist or manual handling belts can reduce carer burden and prevent secondary musculoskeletal injuries. Now, talking in terms of maintaining the mobility and function, as we saw, that is one of the major aspects to look upon in the early, middle, and the late stage. So, to maintain the mobility and the function, muscle weakness results in limitation in function and mobility in patients with MND. Disuse atrophy and deconditioning, as well as muscle degeneration resulting from the disease process, contribute to the weakness. The development of contractures or the imbalance between opposing muscle groups also impact on functional mobility and fatigue. Spasticity is another common feature of MND, and its effects can be severe, both in general disability and in pain, significantly impacting on mobility and function. Physiotherapists play a significant role in maintaining mobility and function in patients with MND through maintenance of range of movement, prevention of contractures, managing tone, strengthening an aerobic exercise prescription, the provision of aids and appliances, and education on correct body positioning and manual handling. It should be noted that the intensity or resistance of the aerobic exercise should not compromise the reserve required to carry out activities of daily living. And such exercises should not be indicated for the middle or the late or even early stages of ALS. So, passive movement should be applied to the. These are the recommendations to the physiotherapist in the early stages. Passive movements should be applied to joints that patients cannot move themselves. Stretching and range of motion exercises from the basis for spasticity management. Education of carers and family members on passive movement and stretches is essential in ensuring passive movements are carried out regularly. The use of standing equipment such as an easy stand or tilt table to support a stretch in anti-gravity and weight-bearing muscle groups should be considered. So let's continue. We were talking about the passive movements and the maintaining of the mobility. Um, so the use of the standing equipment such as the easy stand or tilt table to support the stretch in anti-gravity and weight-bearing muscle groups should also be considered. Individualized strengthening exercise during the early stage of MND are probably effective in improving the function of patients and it should be recommended. Supported treadmill training may be a useful modality in the early stages of MND. The moderate intensity endurance activity may delay the onset of spasticity. So the active and the passive trainers or unloaded cycling should be considered. ideally for home use where spasticity is present. The timely provision and regular view of aids and appliances is essential in maximizing the patient's function. Many patients will require an ankle foot orthosis. Off-the-shelf AFO, example, Swedish AFO, dictus splint, foot up splint, will often be sufficient to support gait. However, in more complex patients, a custom-made device may be indicated. In this instance, early orthotic referral is essential as deterioration may be rapid. Persons with MND use often need a collar as their neck muscles become weaker, and off-the-shelf foam collar can meet the needs of a patient. If it is needed, for example, during transfers, toileting, or while in a vehicle. And the positioning of the patient in a good alignment while sitting or supine can decrease abnormal muscle tone, prevent or reduce spasticity, contractures, and pain, prevent the development of pressure sores, and minimize the effort required for respiration. Adjuncts like riser, recliner chairs, sleep systems, high profile mattresses, providing beds, or high back wheelchairs may be required as the disease progresses to support and correct the body positioning. The physiotherapist should complete a manual handling risk assessment and provide education on handling to the carers so that assisted exercises, transfers, or mobility are performed at an acceptable level of risk. Now, talking about the respiratory symptom management, this is one of the most critical areas in MND, one of the leading secondary complication uh, in terms of mortality. So, the respiratory symptom management is a very important aspect. Now, considering the inspiratory and expiratory and/or bulbar muscle weakness and MND, patients has a major prognostic impact, as we discussed. So the diaphragmatic dysfunction is associated with dyspnea, impaired quality of life, and shortened survival, while an ineffective cough results in atelectasis and pneumonia. The problems can be further complicated by disuse atrophy, shortening, and stiffness of chest wall musculature and reduced lung compliance. Effective cuffing depends on inspiratory muscles to increase the lung volumes, expiratory muscles to produce high thoraco-abdominal pressures, and or on upper airway muscles to coordinate glottis closure and opening. They can all be impaired in MND, resulting in peak cuff flows too low for an adequate airway clearance, which can accelerate the development of respiratory failure and death. The focus of physiotherapists in respiratory management is to monitor signs and symptoms of respiratory insufficiency and to manage the secretions. The physiotherapist should monitor closely for signs and symptoms of respiratory insufficiency. Peak cough flow should be measured regularly in patients with MND. High chest wall oscillation may be useful for secretion, mobilization, but access is limited due to the fact that it is cumbersome and can be cost prohibitive. Oral suctioning using a Yankler is useful in patients with upper airway secretions which are difficult to clear. Patients commonly use this form of suctioning at home. Oropharyngeal suctioning is not normally performed in patients with NAD as assisted cough techniques are preferred and are more comfortable. Pain management. Pain usually is not seen in the early stage, not necessarily, but usually it's not seen in the early stage, but it is mostly seen in the middle and the late stages. Now, pain is a common problem in MND with frequency and intensity correlating with a worse functional score and a longer disease duration. Identification of the precipitants leading to pain is the first priority. Much of this relates to the neuromuscular weakness, including the effects of posture and immobility. Emotional distress, muscle spasms, cramps, pressure sores, spasticity, and constipation may all cause pain, while the presence of pre-existing conditions like arthritis may exacerbate by progressive weakness. Severe pain has been reported in up to 20% of the patients with MND. In particular, shoulder pain is a common feature of motor neuron disease, and incidence has been reported at 26%. Adhesive capsulitis and rotator cuff damage are common and are often attributable to shoulder weakness, spasticity, joint contracture, and decreased range of motion and stiffness. Falls and poor manual handling techniques can also lead to shoulder pain. Physiotherapy strategies such as positioning, stretching, range of motion exercises, or other techniques to address pain of musculoskeletal region can reduce the need for medications. Electrotherapeutic modalities, example TENS and orthotics like splints and collars, are all tools available to the physiotherapist to manage the disabling symptoms. Now, treatment of pain in MND is very similar to that of any other condition from the musculoskeletal region. Early training on correct manual handling, positioning, shoulder care, range of motion exercises may minimize shoulder pain, which is a very common problem in MND. Now, the electrotherapeutic modalities, the splints, collars should also be considered for use to relieve pain. Now, one of the most important aspects of MND, of course, mobility, stability, all those things are important, but then at the same time, it is very important that we do fatigue management. So basically, that's something that we try and prevent from the muscles from getting too tired, and that is equally important, like performing the exercises. As if the muscle is overly exhausted, whatever little functional use we had, even that would be lost. So fatigue management is also a very important aspect of MND. So let's see what can be done. Fatigue is a commonly experienced debilitating symptom and can impact on quality of life for patients with MND. The level of fatigue experience is significantly greater in an healthy age or sex-matched counterparts. Excessive activity, stress, depression, pain, poor cardiopulmonary function, medication, and impaired sleep patterns can also be considered as contributing factors to fatigue. And physiotherapists should therefore be mindful to ask patients about their fatigue level. Now, the management strategy should be directed at minimizing factors known to impact on these contributing factors, referring to the other health professionals as and when necessary. Teaching energy conservation techniques may encourage the patients to pace themselves and reduce the level of fatigue. Uh, Moderate physical activity can impact on symptoms of motor neuron disease, including weakness, spasticity, and depression, thereby influencing some of the factors associated with impaired sleep. However, the intensity of physical activity should be closely monitored for its positive or negative impact on fatigue. So, like we spoke earlier, it is very important to manage the intensity of physical activity uh, for its positive or the negative impact on fatigue. Now, another very important aspect is educating the patient and the helper, the carer, the relative. It is very important for them to know the progress, the aspects of the condition that needs to be taken care of. So, to provide that education, the physiotherapist should avoid providing insufficient information, delivering information callously, or taking away or not providing hope. The cultural and social background of the patient should be respected, clarifying if the patient wishes to receive the information or if he or she wants information communicated to the family. Patients and carers should also have access to information about physiotherapy and MND and get written information when receiving aids and appliances, advice, or exercises. Clinicians should also be available and be able to provide details of the relevant members of the multidisciplinary team in their setting. The management of the patient with MND is challenging, and while evidence indicates that multidisciplinary care in specialist MND centers is recommended for improved quality of life, reduced hospitalization and length of stay, increased survival rates, and reduced disability. A multidisciplinary team approach is also essential in the palliative or primary care settings to augment patient care and outcomes. Patients with MND should be considered a priority for assessment and offered regular monitoring and review. While therapy is primarily aimed at assisting the patient to optimize functional mobility and respiratory status, symptoms of pain and fatigue should also be addressed with a restorative approach. Physiotherapists therefore require a wide range of neurological, musculoskeletal, and respiratory skill and good communication skills. So, to sum it up, basically MND is MND, known as motor neuron disease or also known as amyotrophic lateral sclerosis, is a progressive degenerative disease wherein both the upper motor neuron and the lower motor neurons get involved, which is why both the kind of signs and symptoms can be seen. Which is why it is very important for a physiotherapist to have broad range of skills, considering the signs and symptoms based on the requirement, and go about it accordingly. Maintaining the mobility and the function is one of the most important aspects. Pain management, fatigue management, education to the patient as well as the caregiver. These are one of the major aspects in the management of MND. So physiotherapy does play a very important role in definitely improving the quality of life, and so these are the main aspects to be considered. So with that, we shall end this lecture. If any questions or anything can be noted and be consulted eventually. Uh, for now, I think we shall end this over here. Thank you.